Good evening, everyone, and we welcome you to the webinar on the theme Expanding Horizons in Lung Cancer. Without wasting any time, it gives me great pleasure to introduce our program director, Dr. Randeep Singh, medical oncologist from Gurugram. Over to you, sir.
Thank you, Kashish, Kavina Creations, as well as the other pharma members who have been there to make this as a common platform. I would like to, on the behalf of everyone, I would like to invite all the colleagues, faculty delegates, and this session will be dedicated for, it is 2 hours, mainly on driver mutation positive lung cancer, as well as some data on immunotherapy and small cell lung cancer. It's an miscellaneous topic, but yes, it's a small group. The advantage of such small group can be that yes, we can ask and discuss after the session is over. I would request the speakers to just leave 3-4 minutes or 5 minutes for the discussion so that all the topics are well justified. So with this small brief points to remember, I will hand it over to Dr. Amish, a dear senior colleague and friend. Over to you, Dr. Amish, to start the session, please.
Thank you, Randeep, and thank you for giving me this opportunity. I see the program which you have crafted is quite akin to day-to-day practice. So we have, 4 sessions today. But before that, I just wanted, because, I'm supposed to give introduction. So the overall survival of lung cancer in last 1 decade has increased by 15%. Now, 15% is not a small percentage. And this is possible, I feel, mainly because dedicated biomarker studies have been done and there are new advances in terms of treatment and immunotherapy. So today for 2 hours, we are going to discuss the same in 4 different sessions. In the first session, Dr. Aditi Sarkar is going to take us through the biomarker which is possible in non-small cell lung cancer. Very interesting. ELCC, there was a press release that Spanish registry presented their real world data in how many patients actually do biomarkers in lung cancer. And they were very happy that it has crossed more than 50%. And in fact, this particular statement has been recorded as the practice changing paper of 2021. The registry said 87% of non-small cell and 46% of small cell, they still undergo biomarker study. This is, I think, a quite revolution. In the second session, Dr. Bhuvan Chugh is going to take us through progressing towards cure in stage 3 non-small cell lung cancer, when we all know that after chemoradiotherapy, 70 to 75% of patients do relapse. So Bhuvan is going to talk us through the Durvalumab data, which had initially PFS positive and now also has shown OS advantage. The third session is Dr. Dubey, Ceritinib, Alectinib, Lorlatinib. Which one is the first line treatment in ALK positive metastatic non-small cell lung cancer? And Ceritinib actually remains one of the important day-to-day life decision. And to dive deeper into it, I'm sure Dr. Dubey will take us through that. Dr. Shefali Sardana, after that, is going to talk to us about case discussion on extensive stage small cell lung cancer. Small cell lung cancer is a frustrating disease, even 2022. And I'm sure Shefali is going to show us nice case-based discussion in that. And the last but not the least, the big boss, Dr. Randeep, is going to talk about further deeper dive into NGS. I think we cannot live without NGS today. And Randeep will walk through with the discussion with the esteemed panelists, which I'm sure Dr. Randeep will discuss. And we have here Dr. Vikas Talreja, Dr. Srinath Bharadwaj, Dr. Reshma Puranik, Dr. Rajat Bajaj, and Dr. Fahad Afzal. With that, on behalf of Dr. Randeep Singh, we welcome all the delegates and all the faculty to take this forward. Over to you, Dr. Randeep.
Kashish, can I request you to introduce the speaker and start?
Sure, sir. So our first speaker is Dr. Aditi Sarkar, Senior Research Scientist from the Molecular Diagnostics Department of Dr. Lal Path Labs Limited. And she'll be talking on the topic molecular biomarkers in lung cancer and her experience. Over to you, ma'am.
Thank you. Very good evening to all. And as Dr. Amish sir said, it is really accelerating field of lung cancer with the help of NGS that we are going to see. I think my slides are visible.
Yes, ma'am, your slides are visible.
Okay. So thank you all the team member to giving me the opportunity to share my experience about NGS reporting of the samples and our experience about the biomarker detections and how much we have done it. So today I'll be talking about
If you are
that.
comfortable, can you please make your video on if you are in a comfortable location and you can put your video on. We can't see your video.
Okay.
Else it's fine. Your audio is clear and your slides are clear. Hi. Yes, please go on.
Okay. So today I'll be talking about molecular biomarkers in lung cancer and our experience at LPL. So when we talk about lung cancer, it is not moving. Okay. When we talk about lung cancer, just 1 second.
Ma'am, you'll have to use the arrow keys to go back. Oh,
yes. Yes. So when we talk about lung cancer, it is not a single disease. It is it has histological differentiation like non-small cell and small cell. Among that, squamous cell adenocarcinoma, and with the biomarker classification, it can be many. So when we are talking about drug sensitive or targetable therapy sensitizing lung cancer, the major part shared by the EGFR, that is nearly about 17%, then ALK and a lot many like ROS, BRAF, NTRK, PIK3CA, HER2 and many. And the major part also shared by KRAS is nearly 25%. So why we are talking so much about biomarkers and why we are talking so much about targetable therapy, when we see some kind of study like this, I have included just two, but this can help us to understand why we need targetable therapy. Because when we give a targeted therapy to a patient, it increases the overall survival to the patient nearly about 3.5 years, if you see here. And another study, if you can see here, the non-targeted cytotoxic therapy and comparison to the targeted therapy, there is also a very huge increase in the overall survival, that is 31.8 months. So how has this mutation testing in the lung cancer evolved? Because we need to know the past and then we can go ahead for the future. A keen look at the NCCN non-small cell lung cancer guideline. That is, in 2018, if you see, there were only 4 actionable drivers. In 2020, it increased to 6. And this is the journey from 2001 to 2020. There are many more. But when we are talking about 2021 in NCCN guideline, there are nearly 11 actionable drivers. There is a drastic increase. So this drastic increase is actually contributed by many partners. It is not about only the therapy development. So we have to find out the therapy on which the target, we have to find out the target on which we can develop the therapy. So to find out the targets, definitely techniques also matters a lot. So to look back, see how and what we can do the next in the lung cancer things. So when we are talking about lung cancer, EGFR is the most known partner, and most commonly seen part of EGFR is exon 18 to 21. Among that, 19 is the major one. 19 indels are having targetable therapy. Then exon 21, L858R, that is also the major partner. When we treat these two with the first line of therapy, there is a second line mutation which contributes to the resistance part of this. That is T790 in exon 20. When we try treating this T790M with the osimertinib, again, there is another kind of mutation, that is C797S. So these kind of mutations, what happens actually? When we try to stop the tyrosine kinase by inhibiting one type of targetable therapy, then another comes up. Then the second one again comes up, or third one again comes up. It tries to modify itself to progress the disease. So we are not able to cure the disease, but definitely we are delaying the progression of the disease. So that's how the targetable therapy may help the patient with the overall survival. So in this slide, this is a kind of busy slide. If you can see, there are so many mutations, but it is the less commonest mutation in the EGFR exon 20 insertion. So if we are following real-time detection, like RT-PCR detection of the EGFR, that is the probe-based method. So when we try to detect this kind of mutation using the RT-PCR, we have to have these many probes for the detections. But that is very difficult. Either we have to put so many reactions or we have to multiplex so many times, which may lose the sensitivity of the assay. So, but the unfortunate point of this is that we have drug for it is the exon 20 insertion. So we should detect it accurately so that patient can get the benefit of the drug. So we need to have a very good technique like sequencing, which can identify which kind of mutation it is, and then we can go ahead for the therapy. So all those things are there. If you go with the real time, we may get a negative thing, but if you go with the Sanger sequencing, then there is a problem with the sensitivity. But then NGS or kind of thing can help in the technique wise to detect this kind of insertion and help the patient benefit from the drugs. The next biomarker is KRAS. The fortunate thing in the KRAS happened in the last year, that is patients are able to get the drug for the KRAS G12C, one of the biomarker. And the major part of it is that near about 40% of the KRAS positive patients are actually positive for the G12C. So it is a very good news for the KRAS positive things, for KRAS positive patients. And it is a good thing happened last year. And then we go for the BRAF, that is the next biomarker. In every other biomarker, we have a single therapy, but in BRAF, there is a combination therapy, that is dabrafenib with trametinib, that is given, and that is the known therapy for BRAF V600D. It targets BRAF V600D along with its downstream signaling molecule, that is MEK. So, and with this combination therapy, it increases the overall survival drastically when it is given alone. So that's how it is included in the therapy as a combination. ALK is another one, which is the common partner common fusion partner found in the adenocarcinoma non-small cell group. Near about 7% of the samples are ALK positive. And good thing in the ALK happened that the alectinib, which is the selective ALK inhibitor, was found, and it can also cross the CNS blood-brain barrier, and it can also handle the metastasis in the CNS. Another partner biomarker, that is RET. When we talk about RET, KIF5B is the major partner, and that's how we see KIF5B and RET fusion. But there are a few more other partners like CCD6, NCOA4, TRIM33. And if we do not do a particular type of targeting these kind of fusion partners, NGS also can detect this RET kind of RET fusions in all the cases. And we also have therapy for the RET like vandatinib, cabozantinib, and pralsetinib, and so on. The list is given in the down part. We also have a MET. In NGS, if we see the newer technique in the NGS, MET amplification is also detectable. Like we can also detect MET amplification by NGS, and we can also do a CNV in liquid biopsy also for the MET. That is a good thing, which is the upcoming thing in the field, and that if that gets very much optimized, I think that will help the patient very well. This is a very nice thing happened. TRK inhibitors, NTRK, that is neurotrophic receptor tyrosine kinase inhibitor. Good thing in this is that the FDA didn't give any approval for a type of tissue. It has been mentioned here that a solid tumor, any solid tumor with the NTRK fusions can get the benefit of the NTRK fusion inhibitors. And if you see in this particular publication that overall survival increased drastically with the NTRK fusions positive patient. So why we are talking about so much of molecular detection over the traditional technique, and I just mentioned so many times about the NGS. Why it is that? Because when we do a tumor biopsy, in the case of lung especially, the biopsies are very small. We get very small tissue in the block. It goes to histology department. It goes for the classification adenocarcinoma or small non-small cell lung carcinoma. That has to be done. And then it goes sequentially like BRAF, EGFR, PIK3, and ALK for the IHC and FISH, all those things. So if you go sequentially, we actually lose or exhaust the tissue for all the tests. So if we can have a one patient and one test kind of thing, it will be an easier one. And then we can also save the tissue if it is required for some other more test, if it is required in the future. So all those things can be solved by only one kind of test, that is NGS. But why NGS? Because if you see in this page that there are many techniques available in the market: Sanger, pyrosequencing, next generation sequencing, real-time PCR, ARMS PCR, digital PCR. So when we compare all the sensitivity, Sanger, next generation sequencing have a decent sensitivity, 2% to 0.1%. It can also handle tumor tissue as well as cell-free DNA. So it can help in both the way. It can also rule out the tumor heterogeneity when we do it with the ctDNA. So all those things can be ruled out, I think, by the NGS. So I would just give a glimpse of newer updates. We talked about BRAF V600E in the earlier section, but then there are few cases like case reports which are available with the BRAF fusions also. Though it is very rare, but those patients who are having BRAF fusions also should get some targeted therapy for that particular fusions if it is available. So when we have, when I have just studied, I was just going through, I just saw nearly about 17,000 patients, only 42 patients were positive for BRAF fusions. So it is little rare, but still those patients who are getting positive, they should have the therapy for it. So maybe this kind of things by NGS detection may open the door for the newer kind of therapeutic discovery or clinical trial, if you say. So all those things also should be led by newer techniques or updated techniques. That's what. If you see here in the liquid biopsy, there is a vision trial. Liquid biopsy accelerate the patient enrollment. So why it is only a particular kind of target? If we do a liquid biopsy by NGS, we can cover a minimum of hotspot panel, and then we can screen the patient for their disease progression by liquid biopsy. That also will help to accelerate the patient enrollment, also help in the patient management. So in this page, I have just listed 4 techniques, and I just highlighted ultra rapid TAT for NGS. I just wanted to justify this. Why, like people generally think that NGS is having so long TAT, 10 to 15 days it is. But when we compare the sequential thing, the 50 gene or the 50 mutation, just think not even 50 gene, not even 20 gene, not even 12 gene. If you just think 50 mutations, in real-time PCR sequencing and ddPCR, it will take how much time and how much tissue it is. So with that thing, if we just understand how much it can give the output, I think we can consider it has an ultra rapid TAT. If we are giving result in 10 to 15 days, it means we are covering hotspots for all the 50 or maybe the full gene for all the 50. Generally, we do a cancer for the, we do a hotspot for the cancer. And also it has a sensitivity to 2% to 0.1% when we use cell-free DNA also. It can also rule out tumor heterogeneity in the case of sample type like ctDNA. That is also helpful for the patient. Now I would like to just give a glimpse about our samples. We have 3 codes for the NGS lung panel. One is with FISH, one is with NGS and FISH, one is with FISH, IHC and NGS. So in the 12 gene lung cancer panel, that is a panel where we can detect fusion as well as hotspot in the single panel, and we use DNA and RNA based panel for this. And the upper one, NGS 50 gene panel, we do a DNA based panel for that. So till last year, we have done near about 650 samples in 12-gene lung cancer panel, and this is how the share it is. And I just wanted to highlight, if we see the unfit and no tumor fraction, no tumor fraction, I cannot justify because it is clinician driven sample. So if you see the unfit, that is also very less. We have almost 96% samples successfully reported for this case, these many cases. So I would just like to highlight our reporting format point. Whenever a sample is getting registered for 12-gene panel or like 8-gene panel or 5-gene panel or 50-gene panel, if it is not registering for 50-gene panel also, we give the pathogenic or likely pathogenic mutation obtained from any other particular gene in the panel. So it is something like that. We are actually giving the report for all the 50 genes, whatever it is registered for. It is not only this 8-gene panel or so. So any pathogenic mutation is there in that particular patient, we always give a note to that we have found this pathogenic mutation, and this has a pathogenicity as per ClinVer or whatever cited database. I just wanted to highlight 2 case studies here. This is a 65-year-old male, what we got, and diagnosed with metastatic adenocarcinoma, tested for EGFR ALK ROS1. Patient was found to be positive for L858R. Started on Gefitinib, but there was no response. Then again came back for the NG-based panel with this 6-gene. MET amplification was positive. So this MET amplification was actually the cause why he didn't respond for Gefitinib. So if we would have done the NGS in the first place, we would have saved time, we would have saved the no response phase for the patient, and all those things can be managed little more easier than this. In another case, 62 years male, diagnosed with invasive carcinoma, tested for EGFR ALK ROS1 rearrangement was positive. Started on Crizotinib, there was no response. Why? Then again, patient tested, came for the NGS panel, tested on KRAS, it was positive. So that was the reason. Maybe the KRAS positivity was not helping the patient for the Crizotinib response. We have got several odd kind of things, like so many mutation in a single patient. We got one patient with 3 coexisting variant. MET copy number detection was high. MET mutation was exon 14 skipping was there. There is a deletion in the splice site. That is the reason maybe exon 14 skipping was there. And there is a rare mutation in the exon 7 in EGFR. So all those things, complicated mutation, you get it at once, and all those things can be managed like before starting the treatment only. There is another case where patient was positive for EGFR exon 20 duplication along with a MET missense mutation. So here I would like to summarize. Optimal tissue sampling and management is the key to identify prognostically important genetic subtypes in the lung cancer. Individual gene testing is still going on, but we need to graduate to a multi-gene testing in view of limited tissue samples like lung cancer samples, the biopsies. Liquid biopsy is highly sensitive, need no biopsy. It can give a better outcome to rule out the tissue heterogeneity, and also can help in the monitoring of the patients easily for the secondary mutations or a disease progression kind of scenario. NGS can identify all driver mutations, and it also happen. It is something like that you get a mutations which is not there in the guideline, but it also helps to open the door for the newer therapeutic options and clinical trial scenarios. NGS is tissue proficient because we use very less tissue. It is better half for the precision medicine. RNA-based sequencing has overcome most of it shortfall. Existing NGS-based DNA sequencing. So it can also give a RNA and DNA panel at once with the fusions, with the CNVs, and that helps the patient to get the report at once with the all kind of comprehensive reporting format. Thank you.
Thank you, ma'am. If our audience has any questions, or if Randeep sir, if you have any comments, we would welcome them.
So first, I would request anyone from the faculty or delegates wants to ask something.
So I just wanted to, I was pretty intrigued when you showed this, NGS with the other mutations. As a clinician, would you have done anything different? Somebody has a ROS1 fusion mutation positive and the KRAS is present. Would you give a crizotinib a try? Would you not give a crizotinib a try? I think we all can be wiser in retrospect, but then.
So, Bhuvan, I have two comments. First question is for Dr. Aditi, that these mutations, whether she has detected at the time of diagnosis or it is after the patient has been exposed to TKI. Because that is the crux of the situation. If someone has started on Jeftinib and they have not responded, Aditi, and then they have sent an NGS to you after 6-8 months, we all know that MET amplification or mutation is one of the predominant driver in those situations. So Aditi, was these at diagnosis or they were exposed to some TKI for a few months?
That's what they were started on crizotinib. The patient was started on crizotinib, but didn't work. Like crizotinib didn't work. Like in the initial phase only, it didn't work. So then again, they sent the samples to us for the NGS. So then we found maybe the MET amplification or the KRAS positivity was the reason for that.
Okay, and what is so Bhuvan, in these situations, when you have dual mutations, they are very uncommon. The most common dual mutation is EGFR and ALK, which we all must have faced or at least heard from the colleagues. At this point of time, the variant allele frequency also matters. It also matters what type of KRAS was it. ROS1 usually will not have a resistance pathway by KRAS. It is a coexistent mutation and one must be dormant and that must have become dominant later on, because we all are not very clear about the way ROS1 mutations resistant pathways are. But yes, KRAS is not one of the resistant pathways. In the EGFR where she has detected, yes, the things are clear that once the patient has progressed on an EGFR TKI, we all know that MET amplification is one marker which we have started looking. We were aware of this, but we look it for because we have the drug available in the market for it. If you have a EGFR and ALK mutation, the house is divided. You may start with an EGFR and then shift to ALK, or you may start with ALK and then shift to EGFR. That all depends upon the clinical characteristics and the variant allele frequency of your report. That will be my take on the last 3 cases which Aditi presented.
Thank you.
So I certainly, if looking at her case, if Jeftinib was to be given and it didn't respond, it would have been at least 3 months. And looking at the PFS, which usually is 7 months, I would say that MET exon was probably present at baseline. But then, yes, it is a resistance pathway, and there is no doubt. But now, when we're doing EGFR, when we are doing NGS, not only the other pathways, uncommon mutations of EGFR are also coming a lot more frequently. I've had a few cases in which most of these EGFR exon 19 insertions have come in, and probably it leads to a bigger headache. How do you treat those? But then I think. Yes, NGS is the way, but I think the time limit is a problem, nothing else.
Okay, thank you, Aditi. Over to Kashish.
Thank you, sir.
Thank you so much, sir. We'll move on to our next speaker. Our next speaker is Dr. Bhuvan, Chugh, medical oncologist from Gurugram. And he'll be talking on the topic, Durvalumab in stage 3 non-small cell lung cancer, increasing hope for cure. This session is sponsored by AstraZeneca, and with that, I'll hand over the mic to Dr. Bhuvan. Over to you, sir.
Bhuvan, can I ask you to restrict it to 15 minutes?
Yes, sure.
Thank you. Thank you.
So I'll just start with sharing my screen. I hope the video doesn't go off. Yeah, hi. Sorry. So, good evening, everyone. I am going to be speaking about Durvalumab or immunotherapy in stage 3 non-small cell lung cancer. And I'm Dr. Bhuvan. I'm a medical oncologist at Max Hospital, Delhi. So, we understand that we have the burden of lung cancer in India. It's especially in North India. It's one of the more common cancers, and I think it's ranked second only to head and neck cancers in India. And I think the problem lies not only in the incidence, the problem also lies in the mortality rate of it. The mortality rate of lung cancer is pretty high, and almost equal number are detected and equal number die of lung cancer. In today's world and era, I don't think there'll be any oncology department in which the stage 3 lung cancer is not a MDT discussion. It requires a surgical oncologist to give a clearance if there is a multi-station N2 or not, and then it bounces off to the medonc and redonc. Then it's between the redonc and medonc to decide, looking at the lung picture, do they want to go with the radiation singles, do they want to go with RT, CTRT, or first start with the chemotherapy and then move to radiotherapy. So I think there are multiple permutation combinations. So once we have decided that we're going to be treating a stage 3 small cell lung cancer with dual modality, the question remains of doing a sequential CTRT or a concurrent CTRT. And I think with the data which has been with us, it's pretty clear that the concurrent CTRT is the way to go. The chemotherapy regimens which were used with radiotherapy in the non-small cell lung cancer, the more common ones, so I think we all have used etosis, we have used PEMCARB, we have used Paclitaxel. So the one which are the median PFS of most of them have been between 10 and 11 months. And the median OS is somewhere between, it's around 2 years at max. So I think that's where the figures were that, if somebody had a metastatic lung cancer, they would probably survive for a year or a year, 2 months. And somebody had a stage 3 lung cancer, they would probably survive for 2 years. Moving forward, what was the problem was that, most of these patients, they did not have a complete response by the end of their therapies. And the problem was that there was nothing which could be done after that. Patients who had a residual disease, there was no particular chemotherapy which could be given, which could probably deepen the response moving forward. So other problem was distant metastasis. So hence the median progression-free survival, after finishing a therapy of around 3 months was another 4 or 5 months, you would have a progression-free interval, and then probably you'll progress. And the 5-year overall survival was somewhere between 1 in 5 you'd end up surviving 5 years. So as a thing to be done after the CTRT was to try consolidation chemotherapy. I think the consolidation chemotherapy was, we all tried it. Somebody who had a residual disease after the CTRT, the first thing was to give them 2 more cycles of chemotherapy and see the response to it. However, deep down in our hearts, we knew that it'll probably give them another month or 2, but that probably would not lead to a longer overall survival. So there have been no phase 3 studies which have consolidated, or rather which have fixated the consolidation chemotherapy in the stage 3 lung cancer. And there have been multiple other approaches. There have been consolidation targeted therapies also, irrespective of the mutation status. So, but there was no benefit. There was no overall survival benefit as such. Most of the patients, they progressed anyhow. So that's where the role of immunotherapy comes in. So in today's world and era where concurrent CTRT is considered the gold standard for stage 3 lung cancer, immunotherapy is the backbone which is leading to a more safe and effective option as an adjunct to concurrent CTRT. And I think most of us are aware of Pacific trial. It's a phase 3 trial which had non-resectable non-small cell lung cancer. The patients were given CTRT and then they were randomized. They were randomized between 1 and 42 days after chemotherapy. Probably what I do in clinical practice is I start the immunotherapy at somewhere after day 14, between day 14 and day 21. The patients were randomized 2:1 to Durvalumab or placebo. The primary endpoint was PFS and OS. The patient characteristics were well matched, and despite it being a 2:1 division, and what was interesting was there was almost 25% of the patients who had PD-L1 positivity, and prior chemotherapy was given in 27% of the patients. So most of the times in our clinical practice, we are faced with this decision where the patient is unfit to receive CTRT to begin with, where the patient, we do not know whether you can go ahead with the chemotherapy or radiotherapy, and it's taking a bit of time because the lung functions to improve, the steroids have to be given. So I think induction chemotherapy is not a negative thing to be done, and almost 27% patients in the Pacific trial did receive induction chemotherapy. However, almost everybody received a concurrent CTRT, and when they said they received, that means they received 2 or more cycles of platinum-based concurrent chemo CTRT. And as I told you, there was almost 1/3 or rather 1/4 who received induction chemotherapy. So the updated survival outcomes which were published last year, it had shown that at the end of 5 years, there was almost a 43% had remained alive as compared to 33% in the placebo arm. So that's a gain of almost 10%, around 10% in the probability of survival at the end of 5 years. And if you look at the median overall survival, it's 18 months survival between the receiving Durma versus receiving placebo. And I think it's a huge benefit of, it's almost double of probably what we have said. Well, not double, but then, when, as I told you, when we began this talk, that oral survival for a stage 3 would in a generation or for 10 years before was around 2 years. And now I'm adding 1.5 year extra to it just by giving one drug. So that's where it is. And the updated PFS is almost 1/3 of the patient were progression free at the end of 5 years. So what you're saying is, at the end, if you give Durvalumab or if you give, if you employ your drugs well, at the end of 5 years, 1/3 of the patients would be progression free as well as progression free and alive. And another 10% might have progressed, but they will still be alive. So and this is despite there's obviously patients had continued with their anti-cancer therapies. In Durva, 41%, and in placebo, 54% of patients did receive further anti-cancer therapies, and the patients in the placebo arm did go on to receive immunotherapy. So it's not that immunotherapy was not given to the placebo arm later; it was given, and this benefit is despite that. What is interesting to know is the good systemic control which is provided by the Durvalumab. Most of the progressions in the Durvalumab had been a thoracic progression, intrathoracic progression. So you can't call it as a it is not a proof of it, but then it's somewhere near that. Majority of the progressions which happened in Durvalumab arm, they were in the thorax. However, what it did was it still further improved the intrathoracic progression time, and the median time was somewhere between, it's almost 2 years as compared to around 9 months with placebo. Not only did it improve not only did it improve the extrathoracic spread, it also improved the extent of extrathoracic spread. So majority of the patients who had Durvalumab, when they progressed, so 8.8% had extrathoracic progression. Most of them, or rather 50% of them, had only one lesion. And on the contrary, if you look at the placebo arm of it, 16.5% had extrathoracic lesion, and it was almost divided between 1 lesion, 2 lesion, and 3 to 5 lesion. So there was the number of extrathoracic spread is also limited by the use of immunotherapy or Durvalumab. It's a safe drug, we know. Probably we've all used it. I possibly till now touch would have not faced similar greater difficulties. However, yes, pneumonitis is something which obviously scares us, and it's a pain when it happens, and it kind of delays your therapies a lot, and it's difficult to manage. There's a lot of cough, there's a lot of symptoms, and that has been there. But what has been interesting to know is that the difference is not much between the less than 14 days and more than 14 days. It's, however, it'll be easy to say that you can start after 14 days. The pneumonitis may be slightly lesser. In the in the real world setting, I think with the same trial, with the same exclusion criteria, in the interest of time, I'll just skip the slides. Basically, patients who had pneumonitis at the end of CTRT were excluded, and patient had to have their resolution of CTRT. So what was seen was that the outcomes were almost similar to what they were in Pacific trial. The response rates were same in the clinical setting as well in the trial setting. So I think we are near to the cure in stage 3 lung cancer, and I think probably we'll be moving to it as we start employing newer drugs. We'll be moving towards a total cure there. So just to summarize, the median OS in our Durva arm is around 48 months as compared to 30 months in the placebo, which is a gain of 18 months. The PFS is around 17 months as compared to 6 months, which is again 11 months PFS gain. The 5-year OS, there's almost a 10% improvement in 5-year OS, and 1/3 are alive and progression free at the end of 5 years. So I think it's pretty clear that in today's world and era, there are multiple permutation combinations you can do while using immunotherapy. It's just that with Durvalumab, it's the simplest and the data which has presented to us is the most robust. Thank you.
Thank you, Bhuvan. Any comments, questions from the house? Okay, Bhuvan, any idea about the CNS progression? I mean,
so there is also a subset of it which said that the extrathoracic progression, extrathoracic including CNS progression was lesser in the Durvalumab, and that's something interesting.
Sure, that is something interesting. And do you feel that we all know that immunotherapy is entering, of course, this is a different field, but immunotherapy is entering in the new adjuvant settings, and maybe the minimal N2s, which are borderline N2s, such as one notification.
Yeah, so with the new Nevo data coming in, I think I did when we were having one of these MDDs, I did try to pitch in because I think it came out last week only. The Nevo data, Nevo plus chemo data came in last week only, and I think probably most of these CTRTs, which we were nothing against the radiation guys, but then a few of these patients who were going on to receiving CTRT, they possibly might get converted to a resectable disease with the inclusion of neoadjuvant immunotherapy. I think I'm pretty excited about it.
Yeah. Can I ask one question, Dr. Randeep?
Yes, this is Aditi. Yes, Aditi.
Yeah.
No, Shefali. Hi, Shefali.
Yeah.
Please go.
Yeah. So, Bhuvan, just one question. So, I think this Durvalumab trial had no clear-cut clarity on complete responders. The population was less. So, just a practical scenario, if somebody has a mild ILD, not on steroids, and he has a complete response. So how do you weigh balance the quantum of benefit? So I have come across a couple of patients where this scenario occurred. So practical situation, no clear-cut answer. How would you go about it? So complete responders is a complete blank situation, I think, in any of these trials. Yeah.
I think me and you had a discussion about it, but that patient had a clinically significant ILD, and that time I think the discussion was.
If somebody does not have a clinically significant, but he is having ILD, not on steroids, mildly symptomatic, tolerated CTRT well, complete response. So now how should we go about it?
I possibly the same. My answer probably would be same. If I look at it, the response rates of looking at the rescue of it. If I have a targeted mutation, if it's an adeno, and if I have a rescue targeted therapy I can give once the patient progresses, I possibly may be inclined towards not using immunotherapy at the offset of it, and may use a targeted therapy if he ever progresses. That is, if the patient has adeno and has had a complete CR. If
you have immuno in mind ever, why not right now and why at that point?
So I don't have
because
immuno. I don't have immuno in mind is what I'm saying.
I agree with you. So the quantum of benefit in this subset, I don't know how much it is. Dr. Randeep, any comments on this?
I think see, this is if the patient is in CR and someone has a driver mutation positive, I would not use Durvalumab, even if I know here me and Bhuvan will differ, and I know he will differ. I will not put a patient of driver mutation positive on a Durvalumab maintenance, whether it is a CR or PR. And now, if someone has a CR, it is not only about the trial, but it is also about the relapses. And we all know that stage 3 lung cancer, who is having a significant N2 or N3 disease, they will definitely relapse, and that we all know with our experience when Durvalumab was not there. So irrespective of that, I would like to subject them to 1 year of Durvalumab maintenance. But yes, any driver mutation positive, especially EGFR AL cross, I would not put them irrespective of their response to CTRT. If they have done very bad on CTRT and the lung has been really damaged because of radiotherapy, then I would not intend to do, especially if it is a CR situation.
Right.
So I kind of said the same thing, but it's just that yes, the PR part of it, I'm a little more confused about PR part of it. Anyway, I think we can have this discussion later. Thank you.
Thank you, Bhuvan. Any other comment, or we can go to the next session?
Thank you, sir. We'll move on to our next session. Our next session is on the topic Ceritinib, first line treatment of ALK positive metastatic non-small cell lung cancer. Dr. A.P. Dubey, who's a medical oncologist from New Delhi. Over to you, sir. Sir, are you there?
Yeah.
Yeah.
Good evening, everyone, and thanks to the organizers. And it was quite a lovely talk by my friend Dr. Bhuvan. So I'll be speaking on stage 4 or advanced CLM and the role of Ceritinib as a frontline therapy in ALK positive non-small cell lung cancer. So as been described by my previous speaker, that lung cancer is most commonly diagnosed malignancy, and it accounts for around 11.4% of newly diagnosed cancers. And among that, 85% are non-small cell lung cancer, and adenocarcinoma is most common histopathology. And among that histopathology, it has been said that around 87% of the lung adenocarcinoma patients have targetable or actionable driver mutations. And to detect those driver mutations, we have a number of technologies like FISH, PCR, IHC, and so on. But sequential testing of these mutations might result in exhaustion of tissue and might result in lots of problem in that we will not be able to check for or maybe perform all the tests for the driver mutations. So a single test, that is next generation sequencing, which is massive parallel sequencing, which is able to sequence the whole genome at once altogether, is being considered. And so we have moved from one patient multiple tests to one patient a single test where the tissue is not the issue. And these are the guidelines recommendation, whether it is NCCN or ESMO guidelines. They actually recommend that these molecular testing should be conducted as a part of broad molecular profiling, and should not be only limited to EGFR and ALK and ROS1, and should also include the other actionable driver mutation and next generation sequencing based on both RNA and DNA panel that has to be done. So these are the recommendations by various NCCN as well as ESMO, as well as other guidelines do recommend that multiplex platforms and next generation sequencing should be or must be recommended for the patients, because here we can sequence or we can get to know the driver mutations apart from the most commonly performed driver mutations, that is EGFR, ALK, and ROS1. So what are the benefits and the challenges of NGS? I tend to see the benefits only, that yes, that it is having a very high sensitivity and it is up to 3 times more clinically actionable driver mutations as compared to the current diagnostic techniques. And the turnaround time is also now acceptable. And though it has been said that cost is an issue, but presently most of the laboratory, it is on the basis of the patient assistance program, and it is accessible in like most of the cities. We are able to like perform it, and apart from this, I don't find that there's any technical challenge, because the tissue is a very small amount of tumor tissue is required, and the tissue doesn't remain to be the issue in next generation sequencing, and the turnaround time is also very much acceptable. So non-small cell lung cancer, as I've said, that adenocarcinoma is increasingly diagnosed histopathology, and in them, around 87% of the patients are having actionable driver mutations. EGFR is the most commonly detected driver mutation, and after that, ALK, and ALK is being detected in around 7 to 10% of the patients with non-small cell lung cancer. For patients with all positive non-small cell lung cancer, we have multiple TKIs, as well as we do have chemotherapy if the patients have actually like progressed on these TKIs, whatever we are having with us. So the first generation being Crizotinib, second generation Ceritinib, and now we have next generation like Alectinib, Lorlatinib, Brigatinib, and so on. So this is the study of Ceritinib versus chemotherapy in patient with ALK positive or ALK rearranged non-small cell lung cancer, that is SN4. where the patients of metastatic or advanced non-small cell lung cancer having ALK positive disease were randomized in 1:1 ratio to Ceritinib, either 750 mg in fasting state or chemotherapy, that is PEMSIS or PEMCARBO, till progressive disease. And in the chemotherapy arm, if the patient has a stable disease or the partial response of the, then patients were being allowed to have pemetrexed maintenance. So this is the outcome. You can see the lovely separation of the Kaplan-Meier curves, and Ceritinib almost doubling the median progression-free survival of around 16.6 months vis-a-vis 8.1 months with chemotherapy with hazard ratio of 0.55. That is 45% reduced risk of progression or death, with the overall response rate of more than 70% and duration of response of 23.9 months and 24-month overall survival rate of more than 70%. So this is SN4 Asian patient data, where it has significantly decreased the number of events in Ceritinib arm. That is events, you can see that there are only significantly less number of events occurring, and event-free survival is 26.3 months in Ceritinib arm vis-a-vis 10.6 months in chemotherapy arm with the hazard ratio of 0.66. Although the drug has done outstandingly well, but there was speculation about its toxicity, that mostly the GI toxicity. So that was negated and counteracted by SN8, which was a phase 1 open label multi-center study where the patients of advanced or metastatic non-small cell lung cancer with the ALK positive disease were actually randomized to multiple Ceritinib doses, either 450 mg or 600 mg with low fat meal, or Ceritinib 750 mg in a fasting state, where the primary endpoint was the exposure, that the steady state of pharmacokinetics of Ceritinib, and the secondary endpoints were overall response rate, duration of response, progression-free survival, and so on. So this is a very interesting study because it has actually shown that the duration of response, progression-free survival, and the overall survival were numerically better with the 450 mg low-fat meal dose than 750 mg. As you can see, that overall response rate of more than 80% with 450 mg and 76.9 with 750 mg dose, and the median duration of response in non-estimable in 450 mg arm, whereas it was only 13.2 months in 750 mg. Also, you can see the median PFS, which is significantly longer with 450 mg, that is at least numerically longer, and OS overall survival rate at 36 months is 93.1 with 450 milligram versus 70.9 with 750 milligram in a fasting state. The second common problem with these driver mutated non-small cell lung cancer is brain metastasis. At the onset of the disease, 20 to 30% of the patients will have brain metastasis. So 70%, around 70 to 80% are the patient who does not have brain metastasis. But at the end of 2 years, the cumulative incidence of developing brain metastasis increases. That is, the incidence is more than 50%. So we should actually select a drug which actually address the brain metastasis in patients who have upfront brain metastasis, and also in patients who have no brain metastasis, to stop or to decrease the incidence of brain or decrease the cumulative incidence of brain metastasis when on that particular TKI. So also it has been seen that the patient when on ALK inhibitor, that is first generation ALK inhibitor, the most common site of progression remains brain, that is in around 60 to 70% of patients. So naturally we should select a drug which is having a good CNS penetrability. So the SN4 data also have demonstrated that progression-free survival in patients with metastatic non-small cell lung cancer in ALK positive disease with Ceritinib, the progression-free survival was significantly better irrespective of brain metastasis. You can see the patient with brain metastasis, the progression-free survival is 10.7 versus 6.7 months with chemotherapy, whereas in patient with no brain metastasis, it is 26.3 months with 8.3 months in chemotherapy arm. Also, now seeing the intracranial response rate, see it is more than 70%. You can see the bar chart, it is 72.7%. And you can see on the right side, the CR in around 2 patients, though the number of patients were less, and partial response in 14 patients, that is around 63%, and the stable disease, and progressive disease only in 1 patient with Ceritinib. And so you can see that the median duration of response is 16.6 months with the Ceritinib, and at the end of 24 weeks, around 19 out of 22 patients were showing response with Ceritinib than chemotherapy. Only 11 patients were showing response. So now this is SN4 Asian patient subgroup data, where the drug, a 750 milligram drug was being actually were being given to, or the patients were exposed to 750 milligram in fasting state. Later, the similar equivalence was shown with the drug dose of 450 mg in SN8 data. So here you can see that the whole body overall response rate of Ceritinib is around 65.8, and the disease control rate is more than 80%. And if you see the best overall intracranial response rate, here the disease control rate is 80%. So 80% of the patient with the intracranial disease, will have stability of their disease with Ceritinib as compared to the chemotherapy. Now, the comparative efficacy of the first-line Ceritinib and Crizotinib in advanced or metastatic anaplastic lymphoma kinase or ALK-positive non-small cell lung cancer, and adjusted indirect comparison with external controls. So, profile 1014, which has compared actually chemotherapy versus Crizotinib in first-line setting. There was a trial profile 1007. In subsequent line setting also, the Crizotinib was tested in patients who have actually progressed on chemotherapy. So here it is profile 1014 and SN4 on your slide on your screen. So you can see that in profile, the median progression-free survival is 10.9 months, and it is 16.6, significantly longer, though it is unfair to have the cross-trial comparison because of the heterogeneous population. But for the sake of this study, which is an adjusted indirect comparison, so here you can very well see that this drug is significantly improving the progression-free survival, and also the progression-free survival at 18 months is 50% in Ceritinib trial as compared to 31% with the Crizotinib. And also, if you can see the overall survival, the hazard ratio is 0.76 with Crizotinib, and it is 0.73 with Ceritinib. That is 27% reduced risk of death or progression with a significant p-value of 0.056, just slightly significant. So also this SN4, the Ceritinib has significantly improved the quality of life and significantly prolonged the time to deterioration for lung cancer specific symptoms compared to chemotherapy. Yes, initially there was a lot of speculation about its adverse events, most commonly GI event, but later that SN8, that is phase 1 multi-center randomized trial, has actually counteracted those adverse events, and that was very much tolerable dose, that is 450 mg, and you can see the safety of first-line Ceritinib, and you can see the patients with Ceritinib, though the diarrhea, GI, and transaminitis is quite common with Ceritinib as compared to chemotherapy, but the grade 3-4 events are more with transaminitis. But later, what has happened that with the SN8 data, these adverse events were significantly reduced. Now we have like ALK positive lung cancer is or the ALK mutation or ALK rearrangement is detected in around 7 to 10% of the patient, and we have many ALK TKI, at least after it has been discovered in 2007, we have now third generation ALK TKI, that is Alectinib, Lorlatinib, and Brigatinib. So still you can see this is NCCN 2022 recommendation that were preferred still remains Alectinib, Brigatinib, and Lorlatinib, but still category 1 drug Ceritinib is. So one has to actually cost-effective sequencing has to be done at least in resource-poor country like ours. So though Alectinib and Lorlatinib having a very good intracranial control of the disease when upfront patients are having or patients are being diagnosed with upfront brain metastasis. But if the patients are not having upfront brain metastasis, because Ceritinib is also having very good intracranial control, good CNS penetrability, and in patients who have no brain metastasis, so that is around 80% of those ALK positive non-small cell lung cancer, these patients are doing very well with even with Ceritinib, with the median progression-free survival of 26.3 months, and later they can be actually challenged with other next generation TKI. So that remains a cost-effective sequencing of these LTK, though absolute way of sequencing is currently not known, but this will be my opinion on the basis of the cost of these LTK as of now, what is presently in the market. So we have, after Crizotinib, we have got multiple LTKIs which are efficacious than the first generation TKIs. So we have to select the TKI based on their efficacy. And also one point which has to be remembered is brain metastasis at onset. If the patients are having brain metastasis at onset, then surely alectinib or lorlatinib should be the drug of choice, considering their data, their strong data. But when these around 80% of the patient who does not have brain metastasis, we can actually challenge those patients with the Ceritinib, where the progression-free survival was around more than 2 years in those patients. So to conclude, that in the ASCENT-4 study, the ALK positive or ALK rearranged non-small cell lung cancer, Ceritinib has significantly prolonged progression-free survival and numerically improved overall survival data. And also, PFS benefit was seen irrespective of presence of brain metastasis, though there were speculation about the gastrointestinal and transaminitis with this 750 mg fasting dose of Ceritinib. But later that was counteracted by ASCENT-8 multi-center phase 1 data, where these adverse events were significantly reduced. And the efficacy and safety of Ceritinib was well established in Asian patient population with ALK positive metastatic non-small cell lung cancer. Thank you. Thanks for the patient listening.
Thank you, Dr. Dubey. Any comments from the house? Any question? So if I put it a very gross statement, is it a poor man alectinib or a poor man lorlatinib? That is what you are proposing here. It's quite a provocative statement. Yes.
Only if the patients are not having upfront brain metastasis.
That's why I said, are you proposing that it's a poor man? So I was talking about metastasis. When I talk about, of course, lorlatinib and alectinib are much more powerful drugs and having response rates which you have never heard in even a driver mutation ALK positive lung cancers. Even in brain metastasis, many patients are not able to afford, even as of today, they are not able to afford. 90% of the patients will not afford lorlatinib and alectinib. So are you happy putting them on Ceritinib, or will you put, even if someone affords, then also you will put them on Ceritinib as the first line?
No, sir. If the patient is able to afford alectinib or lorlatinib, then surely I'll put them on those drugs. But if the patient is not able to afford, then Ceritinib should be the drug of choice, sir.
And is anyone using 750, or I think it is a long time now, no one is using 750?
I'm using 450. Sir.
Anyone else is using 750? I think it has been long time. Okay, I think no one is using 750. We are on 450. Thank you, Dr. Dubey, for the lucid lecture. Over to Dr. Kashish.
Randeep.
Yes, Dr. Amish.
Yeah, just,
please.
What you said, I'm just thinking, and this is, I think every time we discuss ALK positive, the sequence always comes in the picture. But I always feel that all the data of alectinib, lorlatinib, what we have is all comparison with first generation. Okay. So the real sequence can be seen if there is a head-to-head comparison amongst all what we are using, which I don't think we will have the data of that. Second important thing is, the PFS of OS and PFS is in a different this thing. Chemo-free interval is also one of the important endpoint in the history of ALK positive this thing. So I think CNS negative may even if the patient is affording and Ceritinib followed by either, Lorlatinib or Ceritinib followed by Elec and Lorla, in a real world scenario, there will be some patients who may be right for this sequence. That is what I feel. Of course, we don't have the real answer, but that is what I feel, that we don't have a head-to-head comparison to say that yes, if the patient is affording, I will put on Lorlatinib only.
I fully agree, Dr. Amish, that even in my practice today, if someone is non-CNS metastasis, I will be happy putting them on Ceritinib, because also my next line, which may be there in 2 or 3 years, is a bit clear. If I put someone on Lorlatinib, it is something which it's just a brain, it's a block in the thinking, but you will agree, when osimertinib first line data of Flora came, we were very confused how to manage progression. Now we are a bit confident that if I put someone on first line osimertinib and there is a progression, I can manage it. To a gross extent, we will have MET, or we will have a HER2 exon 20, or we will have some mutation. Similarly, once someone is progressing or Lorlatinib, getting access to drugs like Entrectinib and others are still very difficult in the post-Lorlatinib progression. So without CNS, I think still what Dr. Dubey showed in the last slide really makes a very practical sense to use.
Correct.
Thank you, Randeep, sir. Thank you.
Thank you, sir. So now we move on to our next talk. And our speaker is Dr. Shefali Sardana, medical oncologist from New Delhi. And she'll be talking on the topic optimal management of extensive stage small cell lung cancer. And it'll be a case-based discussion. So with that, I'll hand over the mic to ma'am. Over to you, ma'am.
Is my screen visible?
Yes, ma'am, your screen is visible.
All right. So very good evening to everyone. And my topic is the optimal management of extensive stage small cell lung cancer, and it will be a case-based discussion. And the disclaimer is that slides are being provided by AstraZeneca, so I'll be putting my views also on it. So, small cell lung cancer, we know 15% of all lung cancer biology is small cell lung cancer. And the small cell lung cancer is a spectrum of neuroendocrine tumor, which is the extreme end of aggressive neuroendocrine tumor. And the management is really a challenge in especially extensive stage, because there is a less than 5% mark of the patient who will cross 2-year overall survival. So challenging situation, tough situation to manage. However, very chemo-responsive tumor, radio-responsive tumor. So I think let's discuss how do we manage case-based scenarios. So this is a gentleman who is 62 years and current smoker, heavy smoker, 30 packs per year. And he presented with increasing shortness of breath, hemoptysis, and weight loss. The patient's general physician found that there is a massive hepatomegaly and there is a mildly deranged liver profile. And he did a CT scan, and it showed that there was a left lower lobe nodule, mediastinal lymphadenopathy, and massive hepatomegaly. So he went ahead and did a biopsy, and it showed a small cell lung cancer histology. Now the next question comes, once we have this kind of scenario, what should be our diagnostic workup for such patients? Or once somebody presents with lung symptoms, how should we work up? Now, biopsy and pathological confirmation is, of course, the basic and the most wanted investigations in such a scenario. And it could be either image-guided biopsy if the lesion is image accessible, actually CT accessible. And the role of bronchoscopy comes because these are mostly central tumors, and sometimes we are not able to access them through image-guided biopsy. So yes, of course, we can access it with bronchoscopy. Or if because of underlying lung conditions, bronchoscopy is warranted, we should go ahead with it. Now the role of mediastinal staging with Ebus or Mediastinoscopy. So a very small percentage, very small rather percentage of limited stage and small cell lung cancer do present in such situation where it is T1, T2 and node negative on imaging. So these kind of patients, of course, should have a mediastinal staging with Ebus or for that matter, Mediastinoscopy if they are planned for a surgical intervention. So this would be a very small chunk. Otherwise, PET-avid nodes or the clear-cut enlarged and characteristic mediastinal nodes on CT or PET with a limited stage small cell lung cancer, you may not necessarily go for a Ebus or a Mediastinoscopy. So now the question comes, okay, how do we stage them? So CT, chest and abdomen with a bone scan, or for that matter, is good enough to characterize. However, it has been shown in trials that these limited stage small cell lung cancer do have an advantage if we do a PET CT. So almost 15% of the patient do get upstage or have a clear-cut answer whether there is a extensive stage disease or any other organ systemic metastasis for that matter. So if somebody on a CT is diagnosed as a limited stage small cell lung cancer, it is suggested by various guidelines like ESMO and NCCN, of course, to have a PET CT to really classify them into a limited stage and curable situation. So now the role of brain MRI, yes, of course, it is included in the staging criteria because we know that most of these patients may have an asymptomatic brain metastasis. So we should do a brain MRI at the diagnostic workup. So this is NCCN guidelines, which suggest that history and physical examination, pathology review, and other routine investigation, of course, baseline CT chest and abdomen, whole abdomen with contrast, MRI brain should be preferred. And PET CT, if limited stage is suspected, should be done. And the molecular profiling, I really have no clear-cut answer that molecular profiling, okay, should we go upfront or not, because this is a tumor where there are so many mutations are found. It's a very immunogenic tumor. So again, we classify according to these diagnostic criteria into limited stage and extensive stage. So by definition, limited stage is basically the presentation of disease which can be incorporated into a single field of treatment. So now this patient, as we know from the previous slide, that CT scan showed a left lower lobe nodule with mediastinoscopy and massive hepatomegaly. So he underwent a PET CT which revealed small, minute, multiple metastases in the liver. And so he was diagnosed with extensive stage small cell lung cancer. Now the question comes, okay, what are the chemotherapy regimen options in first line extensive stage small cell lung cancer? So, do I prefer carboplatin or cisplatin, and on what basis, and number of cycles, again, which is commonly used in practical scenarios, and the views on any other chemotherapy, that is maybe cis-irinotecan or cis-etoposide. Is there any evidence for that? So we'll come to these questions one by one. So now first line treatment for these patients could be a carboplatin or a cisplatin, that is platinum based chemotherapy plus etoposide, which is the preferred regimen. And now after the trials like Caspian and IMpower 133, so we have immunotherapy as the backbone along with the chemotherapy. So if we see the data from these two trials, the IO plus chemo, so what are the results, and are they convincing enough to add IO in this situation? So prior to 2018, the randomized controlled trial actually failed to show superiority of one regimen over the another. So initially, to begin with, the treatment of small cell included the adriamycin or CAV based regimens, and the advent of or the use of etoposide and platinum actually did almost comparative to CAV, if not better than that. And considering the favorable toxicity profile, so etoposide and platinum-based chemotherapy till now is considered the preferred backbone of chemotherapy regimen in treatment of extensive stage small cell lung cancer. So when there was a discussion about the use of IO drug, so there are two good trials which have really shown a PFS and OS advantage in this setting, and they are approved in first line in combination with this EP backbone arm. And to mention two of them is Caspian, which used Durvalumab along with the chemotherapy, and IMpower 133, which used atezolizumab in first line along with chemotherapy. There is some data about pembrolizumab and Nivo or Nivo plus EP also, but because of lack of level 1 evidence showing the OS advantage, these are not level 1 practiced regimens along with the chemotherapy backbone. Now, what is the evidence that we use it in the first line IO-based regimen and not in the second or third? Actually, is the fact that most of these patients who progress on first line therapy may not be eligible for any kind of second line therapy and hence for the third line. So the best foot forward is the strategy which is being propagated. So reserving IOs for second or third line is not going to improve outcomes and should be used upfront. So if we see NCCN guidelines, they also recommend that the chemotherapy along with IO is the preferred or the category 1 indication in a treatment of extensive stage small cell lung cancer. And the options which are recommended are platinum-based chemotherapy with etoposide and Durvalumab. And you can use either carbo or cis, because say, 70% of the patients in Caspian trial used carboplatin. However, there were 30% who used cisplatin also. And in IMpower 133, actually the carboplatin was the preferred drug along with etoposide in this experimental arm. So if we come to the next question, so what point inhibitors in treatment of extensive stage small cell lung cancer? EP plus Durva or EP plus atezolizumab? So however, I am not very pro for doing the cross-trial comparisons. These slides which AstraZeneca has provided should be seen with a caution. So see, there were few differences in both of the trial designs. Number one, that untreated brain metastases were included in the Caspian trial, which used Durvalumab. However, the number of the brain metastasis patients was limited. It was small. And though some of the patients in IMpower 133 also had brain metastasis, but they were not included in the final assessment of the statistical analysis. So they were excluded from the results. So now PCI, the prophylactic cranial irradiation, they were included. These patients were allowed in the control arm, but it was excluded from the experimental arm, that is the Durvalumab arm. And there was no such great categorization in IMpower 133. Now, Caspian and for that matter, Durvalumab propagates that this is a real world data which suggests the superiority of Durva over atezolizumab. But however, this should be taken with a caution that, okay, in control arm where in the real world scenario also, whether we use atezo or Durva, where we do not use immuno, we tend to most of the time give chemotherapy for 6 cycles also. So whether we use atezo or Durva. So I don't know whether this makes a difference in that or not. And regarding the choice of platinum, of course, it was dynamic in case of Caspian, allowing both cis or carbo, while the trial design allowed only carboplatin and etoposide in IMP 133 trial. So if we see the survival curves in Durva plus etoposide and platinum, see median overall survival was 12.9 months in the experimental arm versus 10.5 in the chemotherapy arm, which is approximately as equivalent to the IMpower 133, which showed 12.3 versus 10.3 months, and a good hazard ratio 0.71. And henceforth, they have put that slide for, again, cross-trial comparison, not an ideal way to compare. So the IMpower 133 showed 12.3 versus 10.3, as I highlighted, and Caspian showed 12.9 versus 10.5 months. So approximately similar kind of hazard ratio. Now, is 2-year overall survival good enough to make treatment choice for IO, such an expensive drug? And should we use that 2-year landmark? I think, of course, yes, once we have that kind of results that with only chemotherapy backbone, less than 5% of people do reach this landmark 2-year. So it's worth, I think, using Durvalumab or atezo for that matter as a choice with chemotherapy backbone if the patient is affordable enough to do that. Now, this patient receives systemic chemotherapy, cisplatin, etoposide, and Durvalumab, and completes 4 cycles with near CR and resolution of the liver lesion, as you can see in the imaging. And it's on a 4-weekly maintenance therapy. So, he is being monitored every 3 monthly with the serial scans, of course, along with the clinical examination. Now, the next question comes, should we do a PCI or should we do a brain surveillance in this patient with extensive stage small cell lung cancer in almost a CR? So, there are mixed kind of trial results in this scenario. So there are few trials which have shown, say, if I come to the next slide, so one European study, it showed that PCI, of course, improves survival in patients who nearly achieve a CR or more than a partial response. However, similar Japanese study did not show any kind of improvement. So there is no level 1 evidence. Yes, PCI is must in these kind of patients, but of course, there is convincing data that PCI, of course, limits the symptomatic brain metastasis in due course of time. So yes, PCI is an option in a young, fit, healthy patient who has responded very well to the standard of care regimen. And but of course, the surveillance followed by periodic MRI is equally accepted options. So more depends upon the institutional protocol, more depends upon, counseling with the patient, more depends upon how physician is practicing. Now, this slide we have discussed. The next question comes, is there a role of any thoracic RT routinely for extensive stage small cell lung cancer? So if we say routinely, I would say no. But if we say yes, are there any situations? Yes, of course. So suppose there is a patient who has limited metastasis, who responds very well to the first line standard of care, say chemotherapy, or for that matter, IO or chemo, though we lack level 1 evidence in when we are using IO or chemo to plan thoracic RT. So the conventional studies which utilize chemotherapy only arm and who had a good response to the conventional chemotherapy, the studies have shown that thoracic RT improves overall survival. Though, the data says that the difference is studied at the end of 2-year overall survival because the curves separate at a longer follow-up. So the patients who really do well, who have a complete response, who have a slow biology, I think these are the patients whom we select for thoracic RT and consolidate the response after the first line chemotherapy backbone. So this thing I think I have discussed. Now NCCN also supports a similar kind of scenario. ESMO also suggests the similar kind of thing. If the patient is good performance status, you go for first line chemotherapy or chemo plus IO combination, preferably. And if the patient responds very well, if the patient has a response chemotherapy, and thoracic RT is one of the good options in a good performance young patient, followed by PCI. And now this patient's carry on the case forward. So this patient is on Durva maintenance and is under surveillance imaging for MRI brain metastasis. Now let's think about a scenario if this patient was extensive stage with liver metastasis and had the brain metastasis at the diagnosis. So would our treatment line or approach differ in such kind of patient? I think now we have little clarity on it that if patient presents in extensive stage with upfront brain metastasis and patient has a limited metastasis which is asymptomatic, so you can very well start with the systemic therapy before considering RT for brain, and you can follow it up with MRI and may consider the consolidation brain RT after completion of the induction systemic therapy. However, if the patient is symptomatic enough, so my practice, and for that matter, I think the guidelines also mention that brain RT before systemic therapy is a well acceptable option. And because these kind of patients do have a poor performance status to begin with if they are symptomatic. Now, will your choice of immunotherapy vary? I think there is too early to say that, okay, it is the only Durva which should be used, though the evidence is with Durvalumab because they included the baseline brain metastasis patients. The number was less, but they clearly showed in their trial that patient with brain metastasis, the median overall survival was better, and it was 12 months versus 8.8 months. So I think you can make your choice based on that. But however, I would not exclude Atizo altogether in such a setting. I would treat brain if it is imperative, and then my choice would go according to that also. So however, data is with Durvalumab in such a scenario. So this patient actually received chemotherapy and Durvalumab. We know that now the situation is CR and is on 4-weekly maintenance with Durva. So, from these slides, I think we can conclude that IO plus chemotherapy is the preferable way to treat extensive stage small cell lung cancer patients. And the role of maintenance immunotherapy holds true if we have used immuno with chemotherapy in the induction. However, there is no convincing data that if we have not used immuno in the induction regimen, I mean, immuno may not or cannot help in maintenance. So there is no convincing data for maintenance IO after induction chemo. So now the question comes, does performance status matters in management of these patients, and does performance status of the patient influence your decision on initiating doublet chemotherapy? I think there is no clear-cut yes or no to this question. If we think that performance status of patient is deteriorated because of the disease, I think there is every reason to start him on chemotherapy, even if he is PS3 for that matter. We can do the modifications like dose modification or intensity modification for that matter and build up as the patient's performance status improves. However, if performance status is low because of the comorbid condition, then of course best supportive care has to be brought into the picture and discussed with the patient. Would you consider IO for these patients in PS2? Yes, we have ample evidence that IO can be considered. PS2 is not a contraindication for these patients. And with PS3 and 4, the modifications in the regimen and add on the intensity and doses for that matter is always an option. So now the last question, role of any biomarkers. So this tumor is highly immunogenic. There are so many mutations, TP53, loss of RB1, MYC amplification. There are so many things going on. However, a convincing biomarker is yet lagging, which can prove or disprove its utilization in management of these patients. So I think TMB or PDL1 is not required as such for diagnosis or treatment. None of the trials has shown that it makes a difference in choice of the regimen and armamentarium. So to summarize, first line Durva plus EP has shown sustained improvement. Of course, we have 3 years updated survival coming up, and it is compared with a robust control arm, that is EP backbone, which is the standard of care, and it is reflective of real world practice. Yes, I say, and 6 cycles of EP were allowed in the control arm, and benefits were observed across all subgroups, including the brain metastasis, and survival tripled, actually 3% versus 13% if we see. So there is a hope, but I think there is a long way to go. And it's the convenience is that it's a 4 weekly maintenance regimen. So with that, I rest my talk. Thank you.
Thank you, Shefali. It was very well summarized. I think you have touched upon every aspect of extensive stage SCLC, not only immuno, but also about biomarkers and PCIs, as well as thoracic arteries. So every aspect was very well touched upon. Any comments or any question from the house?
Randeep, can I ask Dr. Shefali a question?
Yes, Dr. Amish.
Yes, sir.
रणदीप एकदम धीमे धीमे बोला सर जल्दी पूछो जो भी पूछना है फटाफट पूछो.
No, we are well in time, Dr. Amish. We are well in time.
Okay. Shefali, first of all, very nice and crisp presentation. I really like the way you present with the confidence. 2 questions. One is again, the data is king in today's world, but when I look at NCCN guidelines, second line mein, not only that none of the IOs are category 1, but there is no mention of even Durvalumab or Atezolizumab in category 2A also. Why do you think this is fair? And second, suppose assume karo ke if one of my patient who I start on cisplatin etoposide, after 2 cycles, patient responds very well and does some fund arrangement. Do I add, is there any data where I add after 3 cycles, 4 cycles, or just as a maintenance IO?
So to answer your first question, sir, like we know that after progression on first line, very few patients are in a condition to make out for any second line treatment. And of course, these are expensive treatment. First line also, 12.3 versus 10.3 months survival. So not a very, very convincing evidence to use it in the second line or third line henceforth. And to answer your second question, I would consider, say, even after 2 cycles, if funds is an issue and patient is going to arrange, if I use it in induction for 2 or 3 cycles, I think that makes a difference for that matter. So if I do not use it in induction in say 3 cycles or 4 cycles, I do not use it as a maintenance. So no evidence for that.
Dr. Shefali, to first question, I'm sorry. In a real world scenario, the performance status is poor normally upfront at the time of diagnosis in extensive stage. Remember,
Right.
5 patients of yours, small cell, you have given cisplatin etoposide. We all know that they do very well for first 6 to 9 months. And when they relapse, we are like a hawkeye, we keep looking at them. So in real world, do you really think that patients who reach second line are of performance status 3 and 4? I think there is something to do with the biology where the second line probably is not working in small cell rather than just the performance status. I would like to ask Randeep. Randeep, in last 5 of your patients of small cell progressing after carbo-eto or cis-eto, do you really think that they come with stage 4 in your clinical practice?
No, actually, you are right. I mean, with the experience and with the counseling, you usually tell them, and you are actually, I mean, you are keeping an eagle eye on them that yes, they have to relapse. They have to relapse. I mean, it is something like it is another opposite way why you are not relapsing. I mean, it's a very bad thought in your mind. But if the small cell is not relapsing after 6 months, you start thinking why it is not relapsing. So they do not deteriorate that much. I wish Dr. Amish has asked a very pertinent question, and I also did look upon data when the patient comes in the later lines after failure of platinum etoposide. Unfortunately, the data does not support to use like using irinotecan with Durvalumab or irinotecan with. I mean, if a patient tells me offline to use it and a patient who can afford it, I would subject them to a combination of irinotecan and immunotherapy. And of course, this is an offline, absolutely no evidence to support. Why it is not there in the guidelines? Because in the second line, immunotherapy has not at all been tried. And the data of atezolizumab is there, but that is just in the form of case reports or phase 2 data of maximum 50 patients where some minimal response rates have been seen in the single agent IO atezolizumab in the third line. And that data of 40-50 patients has not been sufficient enough to come in the major regulatory authority guidelines.
Sir, for that matter, why then atezo maintenance after induction chemo has not worked? So I think there is some catch on that. If maintenance after induction has not worked, would it work in the second line? That is why probably the trials have, I don't know whether have been generated on that lines or not. So there is something which these tumors are highly immunogenic. So the response, what they do in the first line, I don't know whether that response is continued to be maintained in the second line on progression.
I do agree, Shefali, but yes, you will not get the data. Dr. Amish will understand now the drive. I will see very beautifully Durvalumab and atezolizumab. The pharma will not be interested to conduct a trial in the second line. When they say that it is approved in the first line, why you want to use in the second and third line? Their fight will not be there. An investigator-initiated person will not be able to conduct such a costly trial in the second and third line. So now you are not left with any data of using IO in the second or third line. And this is how the science progress in oncology.
Yeah, but Shefali, to answer your question, what I think is now we know that KEAP mutation and STK11 are associated with immunoresistance. Small cell has so many mutations that I personally think is if we start doing NGS upfront in majority of these patients, you can weed out some patients who are anyway not going to respond, no matter what IO, whichever IO you give. I think that would be the next step. That's where I think Randeep will help us understand in his panel that what are these mutations.
So, sir, just one more comment. So STK11, I mean, is for that matter a marker of resistance only in GI. I think none other trials has so far convincingly proved that it is a marker of resistance in every other tumor also. I'm not aware, at least.
I will not challenge you, but I am not aware of GI, but I am aware of lung data. So I think आज रात को घर पे बैठ के पढ़ लेते हैं.
Same here. I am aware of the lung data of STK11 and KEAP1, especially with the KRAS mutation.
I remember lung and KRAS. Yes, Randeep is absolutely right. KRAS, I feel, is the biggest immunoresistant mutation. Yeah. And KRAS is highly prevalent in lung cancer,
Right, right.
So I will start with the last session, and I will just share my slides.
So with your permission, can I?
Yes, Kashish, go forward. Go ahead.
So shall I introduce the panelists?
Yes, please.
So we have our panelists for the panel discussion are Dr. Vikas Talreja, medical oncologist from Kanpur, Dr. Srinath Bharadwaj, medical oncologist from Hyderabad, Dr. Reshma Puranik, medical oncologist from Pune, Dr. Rajat Bhatia, medical oncologist from Noida, and Dr. Fahad Afzal, medical oncologist from Mumbai. And of course, Our moderator is Dr. Randeep Singh, who's also our program director, medical oncologist from Gurugram. Over to you, sir.
Thank you, Kashish. Am I audible and the slides are fine?
Yes, sir.
Okay, so I will just thank you for the panelists. I think we have quite a learned and an active panel, Dr. Vikas, Dr. Shirina, Dr. Reshma, Dr. Rajat, and Dr. Fahad. So I think this is a slide and a summary of what we will be discussing. When we talk about NGS, we have to remember these 3 steps, and I think this is beautifully summarized. It is first is a sample. We very beautifully it is said garbage in, garbage out. Second is the library preparation and sequencing, where as a medical oncologist, we have very less role. Third is the most difficult part is about analysis of the data and how do you interpret a result. And more NGS we all are doing as a medical oncologist. We are realizing more and more importance of molecular tumor board, more and more important of discussing that yes, this particular mutation is important or not. I had recently, it's almost 4 months when the MET inhibitor came. I was very excited to see a MET inhibitor. I mean, just to a MET mutation, but that was an unusual mutation. Then that was discussed in a tumor board, and the VAF, the variant allele frequency was 75-76%. And then I realized and I learned for the first time that when you have variant allele frequency so high, it is a genetic mutation, it is a genetic polymorphism, and it is not a somatic mutation. So this is how you learn. We will be discussing 4 mutations: exon 20, NTRK, MET amplification, and NRG. The experience may be limited, but yes, these are now important for lung cancer. We'll start with the first thing. Anyone can take these points. So we'll start with the first, which has become more common, and we have started looking as well as having patients of exon 20 mutation. So how do you look for exon 20 or for HER2 for that matter? Are you, apart from NGS, are you really checking for FISH for HER2, IHC for HER2, and are you differentiating a exon 20 HER2 versus a non-exon 20 HER2 in your practice? Anyone can take it. I mean, it's a small panel, small group, so please.
So hello, good evening, Dr. Fahad here.
Yes, Fahad.
So, yeah, so in my practice, it's only NGS. I rely on that for checking any exon mutation, but I make sure that they mention the sequence. That is very important. I don't do FISH for amplification upfront, and definitely no IHC so yet. And between exon 20 HER2 versus non-HER2, still yet to inculcate in my practice. So it's only non-HER2 exon 20 which I look for.
Basically an NGS non-exon 20 or exon 20 HER2 may come as a mutation, as a point mutation or a in frame shift mutation, which are most common. Anyone else?
Dr. Srinath here, sir.
Yes, Srinath.
Same here, sir. We're not differentiating between HER2 and non-HER2 as on today, and not doing FISH and IHC really, sir. Just going ahead with the NGS report. That's all.
Okay, so I will just tweak a question a bit. If you have an access to TDX clinical trial, would you then look for a FISH or IHC?
Like your question is, like I agree with the other panelists, most of the times the tissue we have is very less. So all of us go for NGS. But the only twerk in HER2 is that if we have a HER2 amplification on this NGS, we need to confirm it theoretically by at least an IHC or FISH. That is what. So if it is a trial, then we may need to confirm it. We cannot rely on NGS alone. That is only for amplification that I'm talking, not for HER2 mutation.
So if you have an access to a drug TDX, whether a clinical trial or by a compassionate access, you will all like to look for FISH or IHC.
Yes.
I mean, you will have to look for an overexpression of the protein apart from mutations.
Yes.
Okay, and we will come back again to exon 20. Okay, so I mean, we will come to HER2 exon 20 again. So Vikas and Rajat, your options, exon 20 first line. I mean, all the options are in front of you.
Yes, sir. Rajat here. So exon 20 first line, if I have to choose, I'll choose either Mobocertinib or Amivantamab.
Okay, based on what data set?
So the data set, I don't remember the trial names because these are all new trials, but then the data tells us that
and Chrysalis and the Chrysalis is of
Chrysalis is
amivantamab.
yes.
And for mobocertinib, the trial data set is a geometry trial. No, it's not geometry. It's of Met. I don't think so. There is any trial for this mobocertinib data. I will just come back to you. Why I asked you this is because in both the trials, the data set was second line. Both that whether it is Chrysalis, it was already exposed, and in the mobocertinib trial data set,
Sorry,
the
I
data set
missed
is
the
less, but
first.
this year exposure to platinum doublet was an inclusion criteria, and progression on platinum doublet was an inclusion criteria.
Yes.
And that is the same clinical trial running in India across centers is the inclusion criteria. Anyone else?
I missed the first line part. Of course, if it is first line, then it has to be platinum doublet, and then followed by platinum doublet. If there is a recurrence, then I would like to switch to these two, either of them.
Okay, anyone would like to start afatinib or osimertinib? If anyone among the panelists, Vikas is very silent. Vikas, are you there? Okay, anyone else?
Sir, like you rightly said in the first case, the experience is really limited because even I might have seen just a few patients, 1 or 2 patients with this. So I had started a patient on afatinib and had a PFS of 6 months approximately, and then could shift to platinum because all these molecules are not really very easily available. So if we can use afatinib or a high dose osimertinib, then we can reserve the platinum for the second line after the progress. Because anyways, the PFS with either of these is not really very good. And this, what we are talking is exon 20 in the EGFR gene. For HER2, if it is a exon 20 insertion in HER2, then of course it is the platinum which is the choice.
Okay, very well put, Reshma. Yes, you are very right. The HER2 comes here important because there is some data set of HER2, and that is more about poziotinib, which is not yet available in clinical trial in India or across. It is difficult to get that drug where the HER2 point mutations are important. And yes, when you have HER2 amplifications, the TDX, still the trials are being run in India about the Lung Destiny trial. That was where I wanted to point about that HER2 exon 20 and non-HER2 exon 20 are different. Now, yes, there is some data of afatinib. I think most of us used to put them on afatinib. I have put 1 or 2 patients on a combination of chemo afatinib, chemo as well as gefitinib, or in that time when the data of TMH came. But yes, it is not yet the standard. What you do, the standard guidelines suggest platinum doublet as the first line. You can put them on afatinib, which I have just showed you. This is the if you have to look for rare mutations, just look on this paper of Journal Thoracic Oncology. This is the data set which has maximum uncommon mutations on afatinib of around 120 patients. And similarly, there is some data of osimertinib exon 20. The median PFS is 5 to 6 months, and one of the best bet still remains a platinum doublet in these patients. This is now coming to the next line. This is again the first line data, and if you look upon the trastuzumab deruxtecan trial data set, the inclusion criteria, which is in the third column, the lower downmost row, these were also patients who were already subjected to 1 or 2 lines of therapy, and it is only in the TDX trial where HER2 amplifications and immunohistochemistry, like in the TDM1, HER2 amplification was considered. And even in the Destiny trial, one of the inclusion criteria was HER2 overexpression. I think in second line, there is a suggestion with or without a clinical trial. And here I would like to take the help of the panelists. If you have access or if you don't have access, how do you treat them? And do you consider checkpoint inhibitors also? Now, this is who have subjected them to platinum doublet, and now they have progressed on chemotherapy. Anyone can take Fahad and Vikas.
If available, amivantamab single agent would be my choice.
Okay, this is the injectable monoclonal antibody. Yes. And anyone, you have a clinical trial access? Anyone among the panelists have an access to clinical trial in their center or in the city? Shrinath, Reshma?
No, sir, it previously used to be there, but it stopped now, I suppose. So what I used to do is do a platinum doublet and send to the amivantamab trial previously, but now I'm left with only afatinib, probably the second line as of now.
So if you have access, of course, the answer is simple nowadays: mobocertinib and amivantanab for a exon 20, preferably a non-HER2 mutation. Anyone would like to put them on checkpoint inhibitor?
No.
No. Very good. Anyone would like to put no? Second line, third line, no. Okay. And anyone, you have tried TDM1 or pertuzumab, trastuzumab combination? I have tried and failed in exon 20 when the access was not there to mobocertinib and amivantanab. Anyone has an experience for the TDM1? Okay,
No.
so I don't have good experience of using TDM1 in exon 20. I think coming to the data set which Rajat was pointing out, Chrysalis was I mean the data is there, but it is with very few patients. Chrysalis was the trial which has many arms, and we are talking about here cohort D, which was EGFR exon 20 insertion, and the clinical trial approval is based on this data set. I mean, if you talk about the response rates, it is quite beautiful. The clinical benefit rate is 74%. The median PFS is 8.5 months, but the overall survival is encouraging of 22 months. The responses are good, but the progression-free survival is not very encouraging. Coming to the next, mobocertinib, just to brief it up, it is an oral drug, and it is again the PPP cohort is a retrospective cohort. There were 2 cohorts involved. A good number of patients are there. Again, 24 months median overall survival and a median PFS 7 months. Both these trials are the registration trials who got the approval for these 2 drugs. Mobocertinib, one thing we have to remember, it is an oral drug which makes it advantageous, as well as it has better CNS control as compared to the amivantanab. And there are many trials going on of the combinations of these with EGFR first generation, second generation, when the patient is progressing on them, and exon 20 is as one of the resistance pathway. I think Destiny and Positionib we have all covered in this trial, and Positionib and as well as Duroxetan, if you are lucky enough to have access, these are the first means these are the choice of drugs to be used in the second line after patient progresses on a platinum doublet. And if you have access to these drugs, especially for HER2 exon 20 mutations or HER2 amplifications or HER2 overexpression, these becomes a drug of choice in the second line.
Just for information sake, sir, from Hyderabad, I think Dr. Vamshi Krishna is having trial access to deruxtecan.
Okay, in the lung or in the lung or trial?
Lung, sir.
Okay, in the lung. Okay. And in Delhi, we have, I think, 2 centers where there is access to amivantanab and mobocertinib, both in the second line. And there is a first line trial also at RGCI with Dr. Ullas of a combination of chemotherapy with, I think, amivantanab. Okay, coming to the next NTRK, I think this is one of the most tricky one. And the beauty about the NTRK is this slide that you can use it with IHC FISH, RNA sequencing, DNA sequencing, and sometime my pathologist at my institute is very, enthusiastic, and she sends me a report of IHC being done of NTRK, and I'm in a fix. So can the esteemed panel help me out that whether you do it or you have seen reports of IHC and how do you handle it? And this is regarding NTRK with respect to anything. I mean, here we are talking about lung, but have you anytime ordered a screening test for NTRK and then gone for a confirmation, or you never order a IHC screening test, especially when the patient has progressed on first or second line of therapy? Srinath?
I've never ordered a IHC based test, sir. It was always a part of the NGS because either way we don't have really good access to those drugs. So okay. I didn't really insist on a IHC any point of time, sir.
Okay, Rajat?
IHC I have never ordered. I have looked for NTRK fusion in the NGS only, and I prefer RNA based NGS for NTRK fusion detection.
And I think if you generally I have started looking at the panels, they have started including these. One of the place where I do my NGS is MedGenome. They do include NTRK and one or the other 2 mutations which I will be talking about. I think it is a good exercise to look upon the panel. We usually don't look upon, but if you look at the end of the slide, those 200 genes or others, they are given, and we never look upon that, because for us, if for example I am ordering it for lung, If I'm ordering it for example, breast or other things, it may not be very important. But if I'm ordering for lung, it is always good to see whether these mutations are included or not, so that in future you can opt for that NGS based panel. Even if it is RNA sequencing, they shall have the NTRK standardized and incorporated. Anyone has I don't have any personal experience. Anyone from the house, first we have to give a panel can talk about they have faced an NTRK situation. I have not been lucky enough to face any NTRK either in the lung or in other tumors. Anyone who has an experience? Anyone? Dr. Fahad, Dr. Rajat, Dr. Amish?
No, sir, no.
So
Okay.
NTRK fusions are very rare, rarely seen, I guess. In nowadays, all NGS panels include them, so very rare mutations to be seen. So,
you're right, they're very rare. I mean, we all have. I mean, from the colleagues' experience, also, I think the sharing is less, and that's why if you see the registration trials of NTRK were across tumors, they have only included 70 patients. These are not lung cancer patients. And if the other trial, that is the larotrectinib, had only 12 patients with TRK fusion lung cancer. So even in the registration trials also, the numbers are barely crossing double digit. And we don't have access to these drugs. Maybe the labs, I mean, the labs get sensitized and we start having more. I mean, the moment the capmatinib has come in, we have started seeing much more MET, and this is how the labs are also primed to include them. What good about these two drugs? Yes, please. Any comments? Yes.
Sorry, just Amish here. You talked about immunohistochemistry. If I have understood correctly, but you can correct me, this is different from HER2 or any other IHC. In NTRK, IHC just shows the protein expression on the cell, while the fusions are seen on the NGS, and that depicts that the larotrectinib and entrectinib will work. So even though NTRK IHC is positive, does it have any clinical significance as of today?
No.
So, Ramesh, yes, please. Yes, I think someone would like to take that question. Please go ahead.
Yeah, I was saying that Dr. Amish Vora is very right in saying that IHC is actually a protein which is being looked at, and even if in NTRK we have a protein which is there, we have to, that can be used as a kind of a screening tool, but then that is certainly not a definitive way to diagnose the NTRK presence, and we have to look for the NGS where the NTRK fusion has to be seen in the RNA sequencing to confirm it.
I fully concur with Rajat. I would not treat someone on IHC. IHC is, yes, you can use IHC as a screening so that you can start looking upon the expanded access, because it takes time for the entrectinib, larotrectinib to come in. I have tried, I had 2 patients of IHC positive. Both of them had a negative on NGS. Even a FISH can be used, but yes, FISH is very difficult because NTRK can have 9 or 10 fusion partners. So you have to apply 8-10 FISH probes, and that's why NGS has become the most practical test to be used. But yes, we would not use the drug just on IHC, never.
It is almost like ROS1. We over the years come to know that ROS1 gene rearrangement also works like the same way. So it is almost like ROS1 gene rearrangement.
Thank you, Rajat. And what I wanted to say with this slide, that yes, as we are trying to get access to entrectinib and larotrectinib, the science is not stopping. It is, you can already see that the algorithms have started coming in the clinical trials of the patients who are progressing on the first line NTRK. The second line NTRKs are already in the later developments. And this applies to repotrectinib, which we all know is already in the phase 3 trials, or phase 2 trials for ALK, and as well as ROS and NTRK as the second or third generation inhibitor. Coming to the third, this is one of the most interesting, and I would try to wind up and have very fast comments. Do we do only MET NGS, or do we do a MET FISH also for amplification as of today? And if we do a FISH, what is your cutoff? Reshma?
Sir, as of now, I think NGS for MET is done, and in which we see the gene copy numbers. I am not yet very sure about FISH for, and as far as the cutoffs for FISH are concerned, they are variable. In some, I have seen a ratio of 5, and in some trials 1.8. But one thing which is very clear is that as the ratio is better, the response rates are better, so correlated. So the cutoff 1.85 I've seen, so I'm not very sure about the cutoff. Gene copy number, it is 5, sir. The cutoff is 5.
And that is actually becoming more and more standardized, and even NGS also is helping us for the skipping mutations. NGS MET amplification, there is a very varied data that when do you call it as amplified? I mean, NGS fish is, there are two types of NGS MET exon 14 skipping is simple, but by NGS saying fit amplification, we don't know what is the exact cutoff to say that this is amplified or not. But by fish, yes, the cutoffs are 5 or 10. I usually take 10 because I will come to the trial. That was the geometry trial where they have used the cutoff as 10 and the data was there. This was the full text of NEGM. Anyone else would like to comment on the MET amplification or fish?
I think if the ratio is less than 2, definitely the drugs won't work, sir. That is definite.
Yes.
At least
to
try the drug.
Yes, who is absolutely negative.
At least to try the drug, I think minimum is to be 2. As Madam rightly pointed out, the more the number is, the better the response maybe.
And I think we shall all remember that this is even if you're not looking in the first line, always look for the patients who are progressing on EGFR ALK when you have a drug available. It is one of the major resistance mechanisms of EGFR ALK as well as ROS. So how would you like to treat the skipping mutations as well as the amplification? Fahad, any thoughts on that?
So if capmatinib is available, then for either amplification,
capmatinib is available. It is very well available for last, I think, a month now.
So either whether it is skipping mutation or amplification, capmatinib would be my choice.
Okay. Anyone would like to have a counter comment or anything?
So we have capmatinib available certainly, and if we talk about the exon 14 skipping mutation in MET, then I'll be a little more comfortable giving capmatinib in the first line. The geometry data says that if given in the first line, the response rates are better in excess of 60%, with a PFS going up to 12 to 13 months. But having said that, even if it is a MET amplification, although the US FDA approval is not for
Rajat, you got mute. Can you just give the comment again?
Is it audible now?
Now you're clear, absolutely clear. Please carry on.
So if you look at the US FDA approval, then it is only for exon 14 skipping mutation. I think that the reason for that is more because although in geometry study we had both exon 14 skipping as well as the MET amplification, but in the other MET inhibitor trial, the tepotinib trial, there were majority patients who were exon 14 only, and the results of the MET amplification have not yet come in. But then if we have a MET amplification, as of now, I would still like to start that patient on capmatinib because most likely, even if the results come out, they would have a better PFS in the first line as compared to the second line.
Thank you, Rajat. I think you're very well summarized. Yes. Any comments? So tepotinib actually did not include MET amplification. Geometry did include MET amplification. If you just see the highlighted box, cohort, the first one, the cohort 4 and cohort 5 are the skipping mutations, and the response rates are actually quite encouraging. It is 68% in cohort 5B. If you just see on that cohort 5B, it is 68%. This is the first line, and 41% is the second line. When we come to MET amplification, it is not that the responses are not there. Cohort 5A is the first line amplification MET. It is 40%, and cohort 1A is 29%. The data where the approval has come has been based on response rates. The primary endpoint of geometry was response rates, and the approval has been based on response rate, but the cutoff which the trial statistics used was 35%. So that's why exon amplification data is just in a limbo, because the first line it did cross to 40, whereas in the cohort 1A where it was second line MET amplified just 29%. And I think Rajat has very well summarized that not in the first line, but in the second line, if someone has a MET amplification and we are not left with any option after chemo, we would like to use capmatinib as an offline approval therapy in this. Okay, I think I have left with 2 minutes, so I will just take the liberty of moderator and just introduce you to an NRG. If you have been exposed or you have seen this, this is a new mutation, NRG positive lung cancer, and now the data is yet evolving. The NRG is being included. If you see in 1 or 2 of the, if you see foundation 1 or other broad panels, it is there. It is basically in the patients who have a mucinous or a non-mucinous cancer. Because of the apologies to the panelists, because of the interest of time, I will just summarize these slides. And there is some data set to use in afatinib in this, as well as chemotherapy, but nothing works well. If you see, this is the median progression-free survival with platinum chemo is 5.8 months. This is the last row of the first top-end table of the slide. Whereas with afatinib and other immunotherapies also, the responses are very poor. This is another area or niche area where the development is going on regarding the development. I mean, the development of the newer molecules, and this is one of the. This is the registry, and this is the monoclonal antibody which combines HER2 and HER3 and has shown activity in NRG, where the response rates in adenocarcinomas like lung and pancreas have been quite encouraging. So this was what I learned new while preparing these mutations. I also have not faced any NRG till date. And with this, I would like to summarize. I mean, this was my last slide. I would again like to thank all the panelists for their comments and for making us learn about actually diving deep into NGS. So with this, if there are no comments from the house, I will hand it over back to Kashish. Thank you to all the panelists.
Thank you.
Thank you. Thank you very much.
Thank you so much, sir. I now request our chairperson, Dr. Amish Vora, to please give his closing remarks. Over to you, sir.
I'm just wondering, Randeep, XenoQ2-Zumab, that is something we'll have to keep learning till the time NRG1 becomes famous. Very quickly, I have just 2 minutes left. First session, biomarker session. What I learned is EGFR is no longer just one marker. So don't stop at EGFR exon 18, 19, 20, 21, all are different and you have to look at them in a different way. NGS is the best way, although RT-PCR is the quickest way in case if you want to know, if you know what you're looking for. Let's not forget KRAS, because now we have sotorasib, which is FDA approved drug for KRAS and is one of the commonest mutation for lung. 60% of patients can have target mutations if the NGS is done properly. The second, Durvalumab, again, I think, we right now, given the best option or best available option is Durvalumab maintenance in this stage 3 NSCLC. Nearly half of the patients are alive at the end of 5 years, and 1/3 of the patients are alive and disease-free. This is something really, really amazing, and any patient who can afford should be given this option of Durvalumab, where PFS and OS both have shown the advantage of that. In SN4, in Ceritinib session, I think what we learned is Ceritinib is one of the real world options, especially in CNS negative patients. And in non-affording patients, I think CNS negative or positive, you can start with Ceritinib and then you can go on to the 3rd and 4th generation TKI. In small cell lung cancer, again, what I learned is that IO in combination with chemotherapy followed by IO, we have the best weapon right now. 16 to 17% of patients of 3-year survival, again, is sort of unheard in extensive stage small cell. Majority of my patient in my practice succumb by 2 years, do not go beyond 2 years. So that is something which is there. Cranial RT, yes, there is a role. Thoracic RT in a slow growing small cell, and it should be left to the individual physician whether they want to give thoracic RT to that. Panel discussion, Randeep, thanks a ton. I learned a lot today from you. One, now we have the options available. Exon 20, we need to look at, oh, that's a very cute boy, Dr. Fahad's son, I think.
You can keep the video on. We are enjoying it. It's fine. Dr. Amish got distracted with a slow. He just forgot. He just forgot what he was saying.
Exon 20, I think, honestly, Randeep, I also didn't look at sort of HER2 exon 20 and non-HER2 exon 20. And now since we have the data of both amivantamab and, mobocertinib versus TDX1, which is, I'm sure TDX1 is the next drug of 2022 in all the tumor subtypes. There is something, NRG1 was something, again, very new, which we learned. And this MET-RET mutation and amplification, I think we'll have to learn more and more as the drugs are more and more available. Back to Dr. Randeep and Kashish. Thank you so much for keeping me as a chairperson.
Thank you, Dr. Amish. They were really the words of wisdom, and I mean it that you could summarize it in less than 5 minutes about what we have learned in 2 hours. And I think with these discussions and small meetings, I usually enjoy them more, and I think you will agree. These are much more, you are more frank rather than having a big meeting, but we also look forward to meet in person. With this, I would also like to thank, first of all, Dr. Amish for agreeing to be there and give us, overall impression of what we learned today. Also, thanks to Kashish, as well as to all the speakers and delegates for taking their time out. And we are happy to announce that we could finish well in time. Good night and have a nice, safe coming weekends. Thank you.